smaller eyes, and the light pipe is really nice. So this is 27 gauge short, and this is, you know, again, I like to go through the limbus. This is a child that was a child treated with laser that came to me with a cataract after laser treatment. You know, we see these from too much laser or laser into the ciliary body processes. And, you know, we put our trocar and infusion cannula through the limbus. And here, because these trocars are shorter, we can fit them all into the AC. And, you know, just start by, you know, taking the cataract out. You know, it aspirates nicely, which is great. And then going and doing your entire vitrectomy through the limbus. And with this instrumentation, because it's stiff, you can actually complete your entire case that way. And I like to do peripheral iridotomies in all these cases because I am trying to think of all the possible complications I can have in a child after surgery. That way I don't have to go crazy in the post-op period of have to go to the OR too many times. So this is a 42-week-old Down syndrome child with congenital cataracts. Again, this is the short system. We can go and through the pars plana and remove the lens nicely. And this way, because I know exactly that the back of the eye is okay, I like to go through the limbus when I don't know what kind of traction I'm gonna have in the anterior retina, and you can complete the case nicely that way. And this is a stage 4 ROP detachment. And in this case, I decided to do the surgery temporal because there was so much traction in the temporal quadrant that I didn't want to put my instrumentation there. I knew that if I was going to put it there, I would create a rhegmatogenous component at the time. So I did it a little bit different. And here you will see that I put my instruments on the nasal quadrant, 180 degrees away from me. And this is the Alcon system, which is what I had at the time. And you can see that there is a lot of traction. You will see there's dragging of the macula into all this temporal quadrant. Remember, I'm sitting temporally. And I am trying to remove all the tractional component. Now, elevation of the highlight or no elevation of the highlight in these cases it's difficult. Sometimes it comes, sometimes it doesn't come. So many times I try as much as I can and it won't happen, and that's okay. Sometimes I actually can lift it and then I will. So every case is a little bit different. I don't have consistency of that. But this is another case of ROP, and you can see there's also dragging here of the retina, and you can see I had the rescan with me, which is really nice because I can actually see the area of elevation, which is temporal here. So what was nice is that as soon as I released the traction, I could see in OCT that the retina relaxed backwards, which was great. In this case, because this kid only had that one eye and they had to fly back to the islands or from the Caribbean, we did silicone oil in this eye. But I will tell you that these systems are great for ROP surgery. And I will say that the DORC system is very modern, and I love the TDC cutter that they have because, as you know, it's very efficient. And you know, in my experience, I think that the TDC cutter in young vitreous, in young, very thick vitreous works really efficiently. So I'm a little bit faster when I use the DORC system. And as you know, we do bilateral surgery in many of these cases because, you know, it's hard to many times bring these kids to the operating room. They're very sick. You only have sometimes one chance. So we wrote a multi-center special multi-center paper a while ago looking at bilateral surgery for many diseases such as congenital cataracts, ROP detachments in children. And you know, everybody who does pediatric retina in the States, we do bilateral surgery just because it's easier. So you do one eye, you undrape, and you do this second eye as a different case the same day. And then let's see, you know, you can't talk about ROP without talking about adjunctive therapies. And, you know, anti-VEGF, which I like to use, as I told you, pre-surgery and post-surgery. And steroid use that I like to use, IV steroids in the perioperative state if I'm in the NICU, and STK at the end of the surgery. But in all these cases, I use this smaller needle that you can see here. We've done studies with the needles. These are pathology slides where it shows you how short it is, so you can actually push it all the way to the hub. And I will show you here, this is in the NICU. You don't have to hold the eye, you don't have to do anything. And the needle, it's so nice because I have the indirect one, and you can actually just let the kid look up if he wants and just go all the way to the hub, and you know you're not gonna hit the lens, which is great. And this is you know, another injection. I usually don't measure, but it's around 1.5 to 2, not more than 2 millimeters. And you know, you can see that you can press it all the way to the hub, and that way you control the eye, and you don't have to have anybody help you or put the baby to sleep or go to the operating room for an injection. So I'll show you a few cases. A 9-month-old female, birth history, born at 23 weeks, birth weight of 560 grams, admitted and intubated in the NICU for 3 months. This was in another NICU, sent to me after progression, after multiple lasers and 1 intravitreal injection of Avastin, and then it was sent to me at 46 weeks. And this is the images that you see. There's a lot of laser, and you can see that laser looks pretty good, but when you really pay attention to the vasculature, you see that there's tortuosity of the vasculature in both eyes. And if you do the angiogram, we go to the operating room, you see that this kid is vascularly active, that even though there's so much laser in this eye, these vessels that have continued to grow over the laser, they reform a second ridge. And I have seen these throughout the years when the vessels, when I used to do laser all the time, when the vessel would start growing and they would hit a little piece, a little area of the avascular retina that didn't have any laser, there was local production of VEGF, and then it would make the ridge come alive again. And I think that's what we're seeing here. So I did indirect laser. I did another injection of Avastin, and I like to do subtenos canalux when I'm lasering at a later stage. I think it controls the inflammatory component. And this is immediately after the laser. You see that I laser all those areas of ridges over them, and I tried to fill in every space that didn't have laser. I gave them an Avastin injection and a subtenos canalux. And this is 2 weeks after treatment, and you see that the most obvious thing is that the plus disease has gone away. So this is a child that, you know, you looked at that eye and you would think, oh my God, there's so much laser, that disease has to be gone. But I think that the evidence of plus disease and the angiogram, which I think is essential in this era of ROP, showed that it's still active. And this is 4 weeks after the treatment. This is 6 weeks after the treatment. And this is 3 months after the referral. And this is one more time in the operating room to be sure that this kid was well treated and that they can, you know, they are also out from outside the United States, so they were going back to their country. Another case, baby referred to me for progression of disease again, despite laser treatment, no prenatal care, estimated age at birth of 28 weeks. And you can see here that this is a very active eye. You have a stage 4 detachment. You see, you know, the ridge is active. There's plus disease in both eyes. And there's laser, but when I see ridges like this in my mind, this tells me that either the laser didn't get really close to the ridge in the first treatment of laser, or it was treated maybe a week or so too late. You know, I think ROP has a moment where you have to treat at that threshold or pre-threshold ideally. And I think when you do that, you avoid complications. So here we do the angiogram, and you see this is pretty active. So what I always do, and this is what I like to do, is any baby that's referred to me, if the laser wasn't given by me, I will do the laser and fill every area of avascularity, and I like to treat it now with anti-VEGF. But in these cases, I like to actually treat posterior to the ridge. I think that once you control the vascular component, you can start lasering posterior to the ridge and start to control that area of elevation. And, you know, it took me some time. You know, I had this baby in the NICU with me, so I could go anytime I want. I do the lasers at the bedside, so I don't have to put these kids in the operating room every time I treat them. So I was able to control this eye without having to do surgery. This is 3 weeks after treatment, and you can see the areas of laser posterior, and then that ridge goes away nicely, and you don't have to do any surgery, which will avoid ultimately a cataract in those eyes that we do so early. This is another child referred to me from the Caribbean, born at 29 weeks gestation, treated with Avastin in both eyes, indirect laser to the left eye, and done at 34 weeks, and now 41 weeks is sent to me. And this is what you see in the right eye, and you see that we have an area of traction superior to the optic nerve with traction along the arcade. And you see that you have intermittent laser given around. And when we go to the operating room and we do the angiogram, you see that this eye is not treated perfectly. You see all those skip areas that will allow this disease to keep being alive. And you have that area of traction along the arcade. And the other, I unfortunately had gone to a stage 5 detachment. So this is a monocular child that was quite active. So I decided just to treat it with laser, anti-VEGF, and STK and watch it. And, you know, nicely, it all went away. All that area of traction settled down. The macula came down nicely, so I was able to avoid having to do surgery in this child. And I will take you to some of the cases that had been sent to me throughout the years. And this is during the time that I was doing just laser to the time that we have evolved to do anti-VEGF. And this is a case sent to me because of progression after laser treatment. And you see the band of traction, the circumferential band of traction and the anterior posterior traction that elevates this. But I will tell you, when I see this, that tells me either treatment that was done too late or treatment that was not close enough to the ridge. This is another case treated with laser, but you see there's still elevation in that area that tells you that they didn't get close enough to the actual ridge. And many times if these eyes are hypopigmented, it's very hard to differentiate between the choroidal vasculature and the retinal vasculature well enough to know that you're there. So one of the tricks that I would do, you know, when I was doing this all lasering all the time, was to start, I would start always in the temporal quadrant, but I would start anterior, and then I would go posterior until I would get a little hemorrhage that would tell me that I was at the end at the beginning of the retinal vasculature or the end of the retinal vasculature. And that way I knew exactly where I was. And a little bit of blood at the ridge is usually not a problem. So this is a case sent to me years ago. The referring person said, you know, Nina, I've treated this patient for 3 sessions with supplemental laser. There's no more laser to be given. So, you know, the patient comes to me and there were multiple areas of skip areas. You can see in that quadrant, there's not enough laser. So if you leave such an area of a vascular retina without laser, it's going to produce VEGF and you're going to have persistence of disease. And this is a case, and you know, this still happens, where you give great laser and you have progression of the laser within, progression of the ROP within the laser area with traction in that quadrant. And this is a case sent to me of progression after laser treatment. You see that we have stage 4B detachments here, but with folds in the macula and active vascular disease. But again, I like to start treating this with my own laser. At the time, I only had laser to treat this. So I treated with laser, completed the laser, I treated it with laser again. And I would do multiple sessions of laser until the disease was all controlled. And look at this, you know, it all goes away. Now with anti-VEGF, I think it makes us more relaxed, knowing that we can control something like that with laser and an injection if needed. And skip areas are important. I was telling you, in this picture, you see that I have a little skip area along the inferior arcade that is still producing VEGF, that's making that ridge continue to be alive. And with time, if you don't treat it, it's going to progress, it's going to pull the retina, and you can have vitreous hemorrhage and dragging of the retina in that quadrant. So you simply go back, fill that area in, and it goes away, which is nice. So a baby born at 24 weeks, 680 grams, sent to Bascom Palmer for progression to retinal detachment after laser treatment. Now at 36 weeks, bevacizumab was injected a week after the laser photocoagulation by the referring doctor, and it was sent to me as a stage 4 detachment. So this is what I had. You see, this is a hasty view. You can hardly make out the nerve, and here's the other eye, and you see these folds, and you see the laser. So when you see something like this, you know that this is not your typical, ROP detachment. This cannot be a stage 4 detachment. And what this is inflammation, severe inflammation after a lot of laser is given, with hypotony and folds of retina in that area. So I basically observed this patient. I gave them steroids intravenously because baby was in the NICU, and eye drops just to keep the baby dilated, and steroid eye drops, and slowly this baby got resolve, all the hypotony resolved, and all the folds of the retina went away, and the baby did fine. So this is something that we see, and when people tell you that laser for ROP, people who are who still don't believe on anti-VEGF for ROP and believe in laser, this is what I see. And I take care of these kids. All the kids I laser in the NICU, I still see them, so I've seen them grown up. And many times you laser them like this, and they come to you with vitreous hemorrhage and retinal detachments that are very difficult to fix. This is a child that came with a vitreous hemorrhage, and you see in that quadrant that doesn't have laser, develop a little tear that we were able to laser in and control this eye without having to do more surgery. So baby born at 24 weeks, 400 grams, transfer after failed laser ×2. And you see that at 35 weeks, we have still vascularly active. The other eye is completely detached. This is when it came to me. You see that we're starting to have that circumferential traction. We have a lot of laser, but we still have plus disease in this eye. So I decided to inject anti-VEGF because I knew I was going to the operating room. And when you hear people telling you that anti-VEGF creates a crunch, I think it creates a crunch if you're treating too late. If you're treating at the right time of threshold for ROP, it's going to do great. But if you wait too long and you already have the formation of tractional component, it's going to continue to form. And this is a beautiful case to show you this. 2 days of anti-VEGF, and you will see how the tractional circumferential traction starts coming in and forming, and you see the vitreous inferiorly starting to organize to really come together and pull the retina off. So this would have been a failure of anti-VEGF after laser because it crunched. Well, it's going to crunch unless you go to the operating room because you already have traction. So we did lens-sparing vitrectomy. This child only had the right eye. The left eye was too advanced for surgery. And I followed this kid for many years. Later, it developed a cataract that we had to remove. That you see there, that's a partial cataract that happens after lens-sparing vitrectomy in many of these cases. And the other eye was lost. But the reason why I wanted to show you this is because we have described at Bascom Palmer something called we call PIMAC, which my colleague Peter Chang, who does pediatric glaucoma, and myself have worked in these very unique cases that are kids that develop ROP that were treated with laser, very aggressive laser, who later in life will develop complications of angle closure and not axial myopia, but high myopia. So we call it PIMAC for pachyphakia, microcornea, and angle closure. Pachyphakia, you would have a lens thickness of more than 4 millimeters, a microcornea of less than 11 millimeters by H2, and angle closure with less than 180 degrees of visible TM. So we think that the retinal ablation causes a decrease in the anterior segment perfusion at the time of the laser, which creates a maldevelopment of the cornea and the ciliary body ring, giving us sonular laxity and pachyphakia. So how do we manage these eyes? Medical management first. If that doesn't work, laser peripheral iridotomy. If not, an argon laser peripheral iridotomy. And if not, then the best surgery would be a lensectomy, vitrectomy, and goniosyneculisis. And this is a really nice case of a patient. She's older, in her 20s or 30s, I believe, 30s. Right eye hand motion, she's monocular. Her best eye is the left eye 20/70. She was premature. Intraocular pressure on the left, she came in with a pressure of 44. And her manifest refraction was minus 1950 in both eyes. She had a history of prematurity, born at 25 weeks, treated with 13 sessions of cryotherapy by Dr. Alice McPherson, who we see here, and had a sclerobuccal placed and removed by Dr. Alice McPherson. So this is her left eye. You see that the anterior chamber looks shallow. Everything is pushed forward. And you see in the posterior pole, you see the amount of cryotherapy that was given to this eye. When we look at the axial length is only 23.8. And remember, it was a myopia minus 19.5 with a lens thickness of 5.7. So a very thick lens and everything pushed forward. So this is the surgery. The vitrectomy surgery is just removing all the traction, and I like to laser those areas. But I wanted to show you the goniosyneculisis done by my colleague, Dr. Chang. So he actually will pull the iris from the angle, opening the angle from the years of this iris being pushed forward. I like to leave these eyes at the end with Avastin because I think it decreases the bleeding that can occur from the pulling of the iris. And it decreases the oozing of the iris anteriorly, which is nicely, but he did this 360 degrees around. And I left this patient with air in the back, and it works beautifully. And you can see how nice the retina looks afterwards. The anterior chamber looks all deep now and nice. And believe it or not, this girl a week later came with the same process in the other eye. In the hand motion eye, she presented with high pressures that we had to do the exact same surgery in the other eye. So remember, this is called PIMAC, pachyphakia, microcornea, and angle closure. And this is a case that I really love. This is a kid that was 10 that was treated with laser and came in with traction of the vitreous in the macula with areas of bleeding because of the traction. And this is performing the surgery. It's nice to have the resight because you can actually see all these areas nicely, and you can see I'm going around. I'm looking at all the tractional component, removing the vitreous, stain it. And with the instrument, I was able to get into that space to start separating the hyaloid with the cutter instead of pulling it. I think that in these cases, if you use forceps, you can easily create a rhegmatogenous component and create more problems than when you're just separating it with your vitrector. This is the EVA machine. This is a 25 gauge Dork TDC cutter. And you can see that I can actually separate all this slowly and gently without using any more instrumentation. I personally like to use the least amount of instruments that I can, and I feel that with the vitrector I can get away with doing most of the things I need. I usually also drain with the vitrector unless there's something unusual. So you see that this is very adherent, and the areas of bleeding that the patient was referred to me, and the areas of bleeding was where the hyaloid was pulling on the vasculature and creating those little local hemorrhages in those in that area. But you can see we can separate this nicely. And it's a little bit of, you grab it, you pull a little bit, you look under to be sure that you don't pull. And here we're able to separate it from the fovea. And you see here, we're cutting that, and it's great. And separating, not doing, and one of the things is not doing necessarily separating everything, but separating what's needed to be separated to avoid any complications in the post-op period. And you see, as long as the macula is separated, we look around, and you don't have to remove everything, which I think, that saying that less is more, I think, especially in these very complex eyes, is true. You don't have to, you sometimes when you're a younger surgeon, you feel that you just have to grab it and pull it and separate it, but in reality, you don't have to. Many times, if you just trim the traction like you do in diabetic retinal detachments, when you have those fronts of tractional neovascular components, that you just trim around it, and as long as the traction is gone in those areas, you're fine. So, it took me a while to tease all this out so that I was sure, and then I was sure that I had separated everything that I needed. But you see, with the vitrector, I'm able to dissect into those spaces without having to use any other instrumentation. So this is a 10-year-old child with a history of laser-treated ROP who presents with a rhegmatogenous retinal detachment. And here, this is 25-gauge surgery. This is the Alcon system. And, there was a hole temporarily. That was my fellow creating a rhegmatogenous component in the area of the rhegmatogenous component. We were able to stain. And I like to use the flex loop to separate the hyaloid in this very tough eye. So you can see that if you go radially, you can actually separate it with the flex loop. Then you can shorten the flex loop and use it as the pick so that you can actually elevate the hyaloid. And then with the vitrector, you can complete the separation of the hyaloid, and your case is done. In these eyes, it's really about the separation of the hyaloid. This is a 30-year-old monocular patient with a history of ROP who developed PVR after failed attempt to repair his detachment. They had done a sclerobuccal vitrectomy with silicone oil, and the patient came to me with progression. And in this area, I'm trying to remove subretinal silicone oil that accumulated in that area. And, sometimes it's hard to do, you see the bubble there. I'm sticking the vitrector in that quadrant, trying to aspirate it. And I'm using the light pipe to push it into my vitrector. So finally, I was able to take it out. But you can see that this eye has a PVR detachment. You will see that now, here we go. And you see there's a rhegmatogenous component temporal to the fovea. So here I have forceps just because I have all that PVR. So I'm pulling, trying to release the traction from the hole. And here I also have another nidus of PVR. And the nice thing about this patient, I obviously put silicone oil in this eye, and I actually, oh, you see the oil is still there. Let's see. And honestly, this is one of the most frustrating things at times. I could have also put some perfluorocarbon and trying to isolate the bubble there, and then let it be sucked by the vitrector. But sometimes this is a tough thing. I'm sure for the surgeons in the audience, this is not super easy, especially when the oil has been there for a long time. It's sometimes hard to remove it. But here I am struggling with it, and let's see, is it coming? And almost there. So you see, I'm trying to push it into the hole. And, could I have done a bigger retinectomy there to release it? Of course, I could have done that, but, these eyes sometimes will require more than one surgery. So you want to preserve as much of the retina as possible. And this is obviously a monocular patient because, that's what we get. And here I am, almost all gone. And there, you see, this is like a struggle, but I finally got it, and there it is. So one that was done, then I was able to go to air, to silicone oil. And in the post-op period, this is something I actually like to do in the post-op period when these eyes are so inflamed and, you know, it's a monocular eye. I actually like to, oh, I have it at the end. Let's see, I will show you. I actually like to inject steroids under the oil in the post-op area, and I injected him with steroids a couple of times. And I actually also gave him an Ozurdex injection in the post-op time, in the post-op period, and then develops obviously a cataract that we have to take out. And here is the phaco vitrectomy. I already took the oil out. I like to take the oil out and then do the phaco, put the lens, but this is the retina. So, you know, he quieted down nicely after the last surgery with lots of intravitreal injections of steroids to quiet the PVR component. And honestly, it worked. He's done really well. He, believe it or not, he sees 20/80 out of the side, and he's been doing great. So, you know, we see a lot of adults with ROP that was never treated. And I think this is a topic we really have to talk about. I think we're going to be seeing more and more of these. And I believe that the most important thing is having the correct diagnosis. Many times they come in, they don't look like premature, that they were premature. They look like normal adults. And many times, you know, my fellow sees them and they don't realize that they have to ask the question, were you premature? And many times they are. And I think the type of surgery that you do to treat those eyes has to be, it's key, and it has to be well thought out. I think those eyes do really well with scleral buckles. Ideally, and if not, you can combine them with vitrectomy. But these are cases, some of them are from Mariana in Mexico. This is a 22-year-old, never treated, and you see the amount of disease in this eye. You see those areas of avascular retina that are very thin and develop lattice, rhegmatogenous components. And in those eyes with the abnormal vitreous, you know, where the vitreous insertion at the end of the vasculature is different. When it's shortened like this one, it's very hard to manage. This is an 18-year-old born at 26 weeks for 100 grams, never treated. And you see the amount of disease and activity that you have in this eyes still. This is one of my patients. This was a 55-year-old that came to the ER. He was treated elsewhere for CMV retinitis. They thought that the myelinated nerve fiber layer that he had in the left eye was a CMV, so they was treating with injections of ganciclovir and foscarnet, and he finally came to our ER, and we realized that what he really had was a rhegmatogenous detachment. We went to the operating room, but my fellow forgot to ask this patient if he was premature, so I'm doing the surgery, and I had decided to do a primary vitrectomy with gas. And as I'm trying to separate this hyaloid, I'm like, you know, this hyaloid is really, you know, unusual, the way it's inserting here. And I'm like, this has to be a premature eye. And after the surgery, we asked him, and he had been premature. And, you know, I wish I would have known that before, because I would have buckled him, but I didn't. So I decided to do a C3F8 18% large bubble that would be there for a long time. Luckily, he has stayed attached, but you see that he developed a stretch hole temporal to the fovea, but luckily there's no traction around it. I didn't touch it. I haven't lasered. I have left it the way it is, and it has not progressed. This is a 33-year-old born at 28 weeks, never treated. Somebody treated it with laser after they noted the area of temporal elevation. And I will tell you, with these eyes, you have to be very careful, because this retina is not really elastic. So many times you treat it with laser and it really gets worse and detaches. It almost like shrinks and detaches. So I'm very respectful of these eyes. I think that many times if you're gonna do something, they do better with a buckle and laser into that area because you're reducing that amount of traction. This is a 27-year-old man born at 28 weeks that you see has had laser around some tears temporally, but has a detachment superior temporal in that eye. So these eyes, you know, I think before you laser them, in my opinion, they do better with buckles. 19-year-old, 28-weeker, and you can see the vascularity of the retina. You see there is some areas of what looks like leakage, but what I believe that really happens, if you were to have leakage in those eyes, you would have neovascular components. So what I think you're seeing is actually the traction of the vitreous in those areas that make that vessel ooze, but it's not real neovascular component. And you see this eye above that had received laser for those holes. I think these eyes, you put a buckle, you can sleep at night. They're going to do fine, and you don't have to worry about progression. Another 32-year-old born at 25 weeks, you see that these eyes regress naturally. They were not treated as a baby, and then with time, they develop all these problems in the periphery of the retina. So I believe the most important thing here is always diagnosing it correctly, understanding that these were premature eyes that were never treated. And why this is so relevant in the anti-VEGF era is that you hear, you know, now that we're treating with anti-VEGF, we have that avascular retina anteriorly. So do we treat it or we don't treat it? And there's all this debate about this. So, you know, if you have these eyes that were never treated and they never formed neovascular components, maybe we shouldn't treat it. And maybe those eyes that we're treating with anti-VEGF will not develop the complications of a natural history of the disease. And these are things that hopefully with time, and if one day we have a good trial, we're going to be able to answer nicely. And this again is what I wanted to show you. I don't think these are neovascular fronts. I think these are just areas of vitreous traction that make this ooze. This is a child that was never treated. Now I believe they're 12 years old, and this is the way the retina looks. So I don't think it's necessary to treat something like this. You can watch it. So the ROP pearls, you know, I think identify the evidence of prematurity on exam in these adults. I think when I teach my fellows, you know, you have to look for those subtle vitreous changes in the periphery of babies that had ROP that regress naturally. I think you have to be cautious with the laser to the vascular atrophic retina of the adult non-treated regress ROP patients. Consider buccal surgery with laser. Many times you cannot separate the vitreous in these eyes because of the posterior insertion of the vitreous base, and wherever the ridge was and it regressed, that area has very adherent vitreous. So do your best, try not to make a regmatogenous component, but many times I just fill this eye with oil and I know that I'm gonna come back to remove the oil, and then you can complete your hyaloid separation because that matures, so it's easier to remove it on the second surgery. And then if you didn't realize in the pre-op moment that these eyes were premature eyes, then do a big expansile gas that's going to be there for a long time. So in conclusion, I think early screening, staging, and imaging is critical. Anti-VEGF has truly revolutionized treatment. Always remember that 100 ROP regresses 100% of the time with one anti-VEGF injection. It really goes away. Now, does it recur? Will it come back? And all that, those questions we haven't fully have the answer because we don't have any good prospective clinical trial that will actually answer those questions that we need, but we know that with one injection, the ROP regresses 100%. I think anti-VEGF gives us improved anatomic and visual outcomes better than we ever had with laser treatment. Combination treatment at times is necessary to manage these cases and sometimes keep them out of the operating room. Surgical instrumentation, we have great instrumentation nowadays. We have great cutters. The TDC cutter is great, and the 27 gauge short torque system is wonderful. Viewing systems need improvement. I think we could have better lenses to function with our instrumentation, our small instrumentation, and I believe Oculus is working on a new type of lens that could make us fit all those instruments. And always, you know, timely screening and treatment truly prevents blindness from ROP. So I think we should not really see blindness from ROP in this world. And thank you very much.
Thank you, Nina. Thank you very much for the presentation. A lot of cases, I mean, a huge experience, and very important messages here. Remember, to all the young generation, that you show very nicely that ROP can be a problem also in grown-up people. Sometimes we don't notice it, and you have these strange detachments, and you realize that they were premature. And also another nice point is that, I mean, ROP, I think, is a patient for life, because you showed some cases where laser, they're in the touch in the future. So remember that, all the young people, that if you have a patient like this, to follow up for the rest of your life. I remember myself when I was in Holland, I had seen patients operated in laser by Zivonovic like 30 years before. They would come back with attachment. So this is really important.
Yes.
Before starting with the Q&A, I have a question for you. You know that here in the Middle East, we have a lot of very advanced cases, like stage 5 bilateral cases. I would like to know, what is your approach on those cases? Do you operate them? You think it's worth to operate them? Or, I mean, how do you approach those type of cases?
No, I will tell you, when I started doing this, I was operating on all stage 5, and you know, you go through the limbus, you remove, I remove the iris, because then it comes into place. So I you know, eat the iris up, I remove the lens, I open the posterior capsule, and I open the funnel. And sometimes you open the funnel in the right place, sometimes you don't open the funnel in the right place, and the case is done because it's a rhegmatogenous detachment. And then you fill them up with oil, but you know, those eyes won't see. But if the case goes well, with time, that retina attaches, and it's something that is hard to conceptualize in stage 5 detachments, that by just releasing, opening the funnel and leaving it detached at the end of the surgery, it will flatten with time, which is nice, and that would be a success to surgery. But the important thing there is, first of all, that the expectations have to be real. You're only working for light perception. So when I started, I would do those cases. Then I decided that I didn't want to do them anymore, that, you know, they're so frustrating, and I didn't see improvement. But then I started to see the patients that I had done surgery on, and the cases that I hadn't done surgery on, that would still come to see me. And the cases that I did, they had light perception. And the family would say to me that, you know, at least, you know, they know it's time to go to sleep, it's time to wake up in the morning. You know, they have a normal sleeping routine, versus the other kids that were awake all night long, and they were very difficult to control as children. So I believe that in my career, I have evolved from having done them to not having done them to doing them. But I will do them. I sometimes get a VEP if possible, to see if there's any conduction. Sometimes I decide to do, if they have poor, you know, low income or poor resources, or they come from a place that they basically have no money, I try to do at least one eye. You know, ideally I try both eyes, but you know, I think that the important thing is the discussion with the parents, because they come with all the hopes in the world that that kid is going to go to school and read, and you know, that's going to be impossible. We're basically trying to preserve light perception vision.
Thank you very much. Adel, Suleiman, if you have questions or there are questions from the audience, can you please go ahead?
I have a point that I would like you to comment on. The safer paper that you published. I would like you to comment on the laser treatment after anti-VEGF therapy at 60 to 65 weeks. How the importance of that approach, and what do you think that the rate of late reactivation of ROP and anti-VEGF treated patients?
Yeah, that's a complex question to answer, but I'll tell you. I think that for me, the only ROP that I see is AP ROP. So all, you know, I have 150 bed NICU where all the babies that I treat are born at 25 weeks or less. When you're starting with those babies, you know, I usually treat, you know, we know the median of treatment is around 36 weeks of gestation, so between 34 and 36 weeks, and we're going to be treating them. I follow those kids until they're 80 weeks of gestation. So I will see them in the NICU, and when they graduate from the NICU, I will see them here, and I will tell you that I've only had to retreat very few, maybe less than 5% of them. And I'll follow them for a long time. Now, when do I do laser? I do laser when I know that that family cannot come and see me, so they're gonna leave the NICU and they're never gonna see me. We live in the United States in a very litigious society, so I wanna be sure that if I'm never gonna see that kid, I don't have to worry about it, so I will laser them. Sometimes the family will tell you, you know, I can't keep coming back every month to see you, so I will take them to the operating room and treat them. But I'm not necessarily treating disease. I'm just making sure that that kid will not progress for the chance of progression. But when I talk to somebody like Mariana Castellanos in Mexico, Mariana, you know, is treating zone 2 ROP. You know, I don't see that type of ROP anymore. You know, that's what I used to see 20 years ago. I don't see it anymore. And she only has to treat 1 injection of anti-VEGF, and that retina vascularizes while the baby's still in the NICU. So I think that, you know, it all depends what type of ROP you're seeing and, you know, the amount of oxygen they're getting. So it's different from where you are in the world, how to manage these patients appropriately.
Awesome. We have Professor Amro. He's with us. He also has a question.
Yes. Hi, everybody.
Hi.
My also comment on treatment posterior to the ridge. I in fact find no added advantage to that, apart from probably creating more inflammation in this tiny eye. And also, I found that lots of cases you have seen with skip areas after laser, and this is probably the laser treater was not very experienced, especially with the use of the indirect laser. I think from the first shot you can cover from ridge to aura 360 degrees with confluent or semi-confluent spots, and there should be no skip areas in these cases.
Yeah, and it's interesting you say that, because I did a retrospective review of all the cases that had been sent to me with cataracts after laser. And what we were able to notice were 2 things, 2 important conclusions. One was that the laser used was an argon laser, which we use a diode. And the second was that it was, all of the cases were by the doctor who was treating it had been just out of fellowship for a year, less than a year. So they all happened during that first year. So I agree with you that the experience of the treater is very important. You know, when I started, I remember I decided to review my own data, because I'm the only one who goes to the NICU. I'm the only one who treats those patients. And I was able to see that if you look at the times that I retreated those patients with laser, I exponentially go down as the years go by. So I definitely got better, and I could do a really good laser with just 1 treatment.
Thank you. We have a lot of questions in the Q&A, and I'm just going to go through them very quickly. Questions about anti-VEGF. So it seems like you're doing most of your cases using anti-VEGF. Is there what's your dosage in those cases?
Yes, I am still using the beta ROP dose, which is 0.625 in 0.05 mLs. That for me works well. I've been using it for years since I started. I understand how it works. I understand how the patients respond to it. And I think that compared to Lucentis, and I think the Rainbow trial was the one who answered these questions, it shows you that when you use Avastin, the recurrence is much later if you're going to have recurrence. So you have lots of weeks of no progression or tranquility, that you don't have to worry about it. Where Lucentis, you're going to have progression earlier.
And a question about those cases with RRDs later in life. Do you find yourself, when you do vitrectomies with the buccal, in the certain cases that you need to do so, do you do it to support the vitreous space, or do you typically support the break?
Yes, I think for multiple reasons. I think one, because you want to obviously support the vitreous space, but second, because many of those areas are really thin, and there's the traction that vitreous attaches in different ways in that area. So I think the buccal really helps. And many of those patients are monocular, so I feel that you have to maximize the procedures that you do. You want to be sure that you can attach that eye with one surgery, and I think a buccal vitrectomy really has a better chance of stabilizing that eye than just a vitrectomy.
And what about the use of subtenon kinologue? Is this something that you do routinely in those cases?
Well, you know, I think the subtenos kinologue is because I have become a pediatric retina surgeon with time, and you have all those parents that are non-compliant with steroid drops and all that. So it's one way that I have learned to guarantee that at least the anti-inflammatory effect is being delivered to that eye. But when you give a lot of laser, when you have a component of PVR, I think that a subtenos really helps you control those eyes. So it's an easy thing to do.
And you mentioned also sub-silicone as well, triamcinolone. You said also
yes,
in one case, in some cases.
Yes, I've been able to save some eyes that have had really inflammatory, PVR under oil with injections of intravitreal triamcinolone and also Ozurdex, and it works really nice. But you have to be consistent. You can't expect to inject it once and make it work, but inject it every 6 weeks for a while, and those eyes really do nicely.
And what about this case of post-laser choroidal effusion? Have you had any issues with the retinal folds that persist?
I've had a couple, and I think Darius Moshfeghi and I wrote a paper years ago about an exudative detachment after a laser treatment when you're treating at 40 weeks or 41 weeks, when you're treating late in the disease. So that's when we started noticing exudative detachments. But you can get either an exudative detachment from too much laser, or you can get hypotony from too much laser. So you have those two. And in my experience, the best thing to do, if you're going to give that amount of laser and it's going to be a lot, or you feel that you press so much and you could have some anterior absorption from the ciliary body, then tell the neonatologist to give them a week course of steroids IV, and that controls the eye beautifully. And then you don't get the exudative component, and you don't get the hypotony either.
And a question about, you said you don't really favor ranibizumab in terms of the reactivation that happens. Did you notice any difference in terms of even the response to ranibizumab in comparison to?
Well, I've never used ranibizumab, but when you look at the Rainbow trial, you see that the recurrence seems to be earlier than they had it with Avastin. I mean, if you're going to have something at Avastin, it's after 52 weeks. And remember that the ROP trial, which is the only way we can really guide us and compare Rainbow, ranibizumab to bevacizumab, is that in the ROP trial, they stopped the trial at 52 weeks. And at 52 weeks, they didn't have any complications. But when you really look at papers that came after, like Mike Shapiro wrote a paper that showed detachments even at 60 weeks after bevacizumab. So we know that there's some cases that are going to progress after that with bevacizumab, but you can make it up to 53 weeks without any complications or progression from bevacizumab.
You brought us out a very nice experience where you started with the stage 5 and then you stopped and then you came back. And it's very interesting to see how a person matures over time. I'm not saying that you're
That's okay. Don't worry. I got it. I got it. I got it.
A question was about, but what if you have another pathology in terms of like corneal opacities that also complicates this situation?
Well, you see, I feel that, you know, at some point, I believe that the group in Detroit, Mike Tracy and Tony Capone, at some point in the past, they were doing PKs, then doing, you know, the ROP detachment, and then doing a PK. But, you know, I never felt that I wanted to do that to a child. You know, corneal transplants early in life, they don't do well, and they always opacify. So if I have a stage 5 detachment where the cornea is white, and, you know, everything is pressed forward, I won't operate on those eyes. I find those inoperable in my hands.
There is one, actually, now Tony Capone is in these cases where there is central opacity, corneal opacity because of the iridocorneal adhesion, is to do the lensectomy, capsulectomy, synicalization release, and then come back in 3 to 6 months and the cornea will become clear. And this is what we noticed in our cases. But I had another case that...
Yeah, but wait, before you finish, I agree with you, but that is only when the corneal opacity is just starter or very minimal. It does happen, but if it's progressed to whiteness, there's no way that's gonna clear. I agree.
I have a case that is a mixture of aniridia with Banus and 360 Limberson deficiency, and in addition to this, stage 5 ROP.
Wow.
So that's a challenge.
That I don't know what to tell you. That sounds like Bascom Palmer cases. That's what happens here. You know, every day it's like something that we haven't seen before, something that we can describe. You know, so it's crazy. Yes, I feel your pain though.
Yeah.
Yes.
Okay, Dr. Marco.
Are there more questions?
Yeah.
More questions, or you're done?
I think we are already. We don't want to keep that.
Yes, Nina, thank you very much. We don't want to keep more than what we promised to keep you.
It's okay.
But
Thank you very much. It's really a pleasure, and I hope everybody stays safe. And I hope to see everybody again at some point. And thank you for...
I hope to see you soon at VBS. I hope to see you soon there. We can redo it again.
Yes. Thank you, everybody.
Okay.
Good night.
stay safe,
See you. Good night. Bye-bye. Bye-bye.
everyone.